Welcome to Mental Health Mini number 33, where we'll talk about caring for patients that have suicidal ideation and treatment. If you're watching this video and you have suicidal thoughts or behaviors, please call the suicide hotline. When we talk about suicide, it's important to understand different terms related to it, starting with suicidal ideation. Suicidal ideation is all the thoughts and behaviors surrounding thoughts of death and wanting to kill oneself. A suicide attempt is an attempt at ending one's life. Suicide completion is when that attempt is resulting in death. And then we have parasuicidal behaviors, and these are self-harming behaviors that are not intended to kill oneself, but intended to make it look like it. When we talk about suicide prevalence, there's a lot of different factors that contribute to the rates of suicide. We do know that suicide rates are increasing drastically, especially following the pandemic and the rise of social media. In particular, we're seeing high rates of suicide increase in teens that may experience bullying, the pressures of social media, as well as due to some of the suicide challenges that have become popular. Typically, we see the highest suicide rates in those aged 45 to 54 years old, as well as those that are over 85 years of age. The population greater than 85 are experiencing bereavement overload, multiple health complications, maybe chronic pain and discomfort, and a lot of that contributes to their idea to attempt suicide. As far as cultural groups go and other groups, we do see higher rates of suicide in American Indians, Alaskan Natives, LGBTQI population, military members, and prisoners. From a geographical standpoint, we do see higher suicide rates in colder places, although we do find that in areas where it may be colder with shorter days, but they eat a lot of fish, we do see lower suicide rates. The theory behind this is that omega-3 has a protective factor at reducing thoughts of suicide. We also know that a lot of countries, like if you look at the map on the right, like Denmark, Sweden, Norway, they have lower rates despite being in a colder region with less light. And the reason for that is partially because of their reliance on a fish diet, but also because they have very good access to mental health care and great health promotion. We do also see higher suicide rates in mountainous and isolated and rural regions. And if you look at the map of the United States, you can see that we have a lot higher of suicide rates in the mountainous regions. When we talk about suicide prevalence in healthcare, we know that patients can attempt suicide while receiving care, and the most common unit that will see that is actually a medical surgical unit. So moving on to physician-assisted suicide. This is a big ethical dilemma when we talk about suicide, and this is the assistance of a provider in helping a patient to end their life. It is currently legal in multiple countries in Europe and throughout the world, but within the US, it's legalized in Oregon, Montana, Vermont, Washington, California, Hawaii, and Colorado. Part of the reason why it's an ethical dilemma is the question of rationality. There's some belief that people that attempt suicide are not rational in their thinking. However, we do know that physician-assisted suicide and suicide in general is not limited to individuals with mental illness. We also see people that have received a terminal diagnosis or are experiencing extreme pain and suffering due to medical complications that attempt suicide. And we also see suicide attempts related to protecting different cultural and religious groups. The pros of physician-assisted suicide that have been identified is it helps the patient to have dignified death. It relieves the patient of their suffering and honors the patient's wishes, so it's a practice of patient-centered care. And it also can reduce healthcare burden if someone is foreseeably needing a lot of healthcare treatment. The cons are that it's very presumptive of the future. It can cause great suffering and burden to others. There's too much empowerment in providers in being able to make that decision and control life over death. Next, we have our risk factors of those that are more likely or have a higher incidence of attempting suicide. And this includes individuals that are unmarried, divorced, or separated, We do know that women attempt suicide more often, but men typically complete suicide more often, and that's because men use more lethal means when they attempt suicide. We talked about some of the age differences and what ages are at risk of suicidal ideation. Other factors include having a lack of a fulfilling faith, being of either the very high or the very low social class, living in rural areas, having lower education levels, being unemployed, certain ethnicities, having mental illness, especially mental illnesses that include hallucinations and command hallucinations telling the patient to kill themselves, having a terminal illness or chronic disease, being part of the LGBTQI community, having a family history of suicide, being a victim of bullying and abuse, feeling hopeless, having a history of an attempt. And when we look at history of attempt, people typically tend to use the same attempt. So it is important to assess for the history because we know one, how likely it is for them to try, but also what their typical methods are so we can try and provide support. Other risk factors include having low levels of serotonin and cytokines and having a lack of omega-3 fatty acids in the diet. Warning signs of suicide is signs that are immediate concern for action, meaning that the individual has likely thought about it to the point that they're at an immediate danger of attempting suicide. Some of these warning signs include talking about it, seeking methods, expressing hopelessness and purposelessness, talking about being a burden to others, increasing substance use, just because sometimes substance use increases impulsivity. So if someone was thinking about it and then they engage in the substance, they may more impulsively act upon their plan. Having a drastic change in mood or behavior. And this is something that can be confusing for some people, but it's often going from a very depressed mood to a very happy, joyful mood. So people assume that the patient has gotten better, but in reality, they may have just had the pressure release of deciding on a plan that can cause that drastic change in mood. And also giving away belongings is a warning sign. When we talk about suicide, there's three categories of suicide attempts. There's the egoistic, and this is a response to separation from others from society. There's also the altruistic, which is completed to support a group's goals or health, or anomic, and this is related to life changes that are temporary, but may cause temporary disruption in someone's thoughts, feelings, schedules, and norms. When we're assessing someone's suicide attempt or suicide assessment, we want to be very direct in our suicide assessment. We want to ask them specifically, do you have thoughts of wanting to kill yourself? We wouldn't want to say things like, do you want to harm yourself? Because a lot of times patients that are feeling suicidal don't see suicide as wanting to harm themselves. They see it as an ending to the pain. So first we would want to assess any suicidal thoughts. Do you have thoughts of suicide? If they do, we can move on to, do you have a plan? If they have a plan, what are your intentions of carrying it out? What is that plan? Have they had any attempts prior? And as I mentioned earlier, attempts may be indicative of current plans. So we would especially want to assess that as well. We would assess for any contributing factors as to why they want to attempt suicide, as well as any protective factors that may stop them from attempting suicide. There's also different assessment tools that we can use to assess the risk for suicide, with one being the SAD person scale. So the SAD person scale looks at different criteria and scores them based on how they answer that criteria. So for example, the first part is sex. If they are male gender, they receive a point. If they are of the age less than 19 or greater than 45, they receive a point. If they're experiencing depression or hopelessness, they get 2 points. If they've had a previous suicide attempt or psychiatric care, they get a point. If they have excessive alcohol or drug use, they get a point. If they have lost rational thinking, either due to psychosis or organic brain syndrome, they get 2 points. If they are separated, divorced, or widowed, they get a point. If they appear organized and to have a serious attempt, they get 2 points. If they have no social support, they get a point. And if they have stated future intent, they get 2 points. Anything greater than a 7 on the sad person scale is an indication for high risk of suicide. The other assessment tool that we can use is Path Swarm. And this assesses ideation, substance abuse, purposelessness, anxiety, if they feel trapped or hopeless, if they're showing any withdrawn behavior, any anger, any recklessness, or mood changes. Another thing that we look at when we discuss suicidality is lethality. And lethality is the likelihood that an attempt would result in death. There are certain things that increase lethality in regards to the method they have planned. One of them is using things like hanging or guns or drowning. And this is why males typically have higher suicide rates, even though females attempt more, because males are more likely to use these more lethal methods, whereas females are more likely to attempt overdose or less lethal methods. Another thing that increases lethality is isolation. If there's not anyone there or around to stop the patient or to find the patient and intervene for medical care, there's a higher likelihood that their attempt would result in death. And then lastly, suicide or substance use can increase the risk of lethality related to suicide as well. And as I mentioned earlier, this is a lot related to the impulsivity that substance use can cause. When we look at suicide, we want to identify any protective factors that can help motivate the patient to choose life over suicide. Different things are resilience, and resilience is the ability to withstand stressful experiences, the level of social support that they have, having effective coping and problem solving skills, having a positive outlook or hopefulness towards the future, having responsibilities such as children, maybe taking care of their parents, work responsibilities that they would feel a motivating factor for life, having good faith, having access to support resources, and having a lack of access to method tools. So sometimes if someone does have a plan and they have access to that plan, we may call family members to take away that access. So if they're planning to use a gun, we would encourage family to take all their guns away and lock them up in a safe area. A lot of times if patients are showing very likely suicide ideation, we can provide them with inpatient therapy. When a patient is on an inpatient unit and they have suicide thoughts and they're a high suicide risk, we want to take care of them by doing a thorough suicide risk assessment, always approaching them in a non-judgmental manner and using our therapeutic relationship to provide hope and help them get past some of the thoughts. We would do a contraband check, which means assessing the patient for anything that they may use to harm themselves, as well as checking their room for anything that could be used to harm themselves. A lot of times this will require a body check as well. We would want to remove any dangerous objects, place the patient on one-to-one monitoring. We could provide them with both scheduled as well as needed medications to help control any impulsive behaviors that may lead to suicide attempts. We would want to provide them with therapy, and we would want to create a safety plan with the patient. So this would be identifying warning signs, coping skills, support resources, other resources, and problem-solving skills. The way that we can support those that are feeling suicidal outside of treatment is to always take what they say seriously. Do not keep any secrets. If someone comes up to you and says, I really am embarrassed to say this, but I'm starting to feel suicidal, please don't tell anyone. Don't keep that secret. Tell someone and help that individual get help. We always want to use active listening and express concern and support for that individual. We should know and be able to refer an individual that's feeling suicidal to our resources. We can remove access to resources to carry out the plan, as I mentioned earlier. You must stay with the patient until they're in a place of safety. If they're immediately trying to hurt themselves, we would want to remove any children from the phone or from the home. And ultimately, We want to approach the patient in a non-judgmental manner. A lot of times after a suicide attempt, whether completed or not, family and friends can have different emotional reactions as well. Oftentimes, they may feel guilt or responsibility for the individual's attempt. They may feel anger or resentment towards that individual. They may feel confusion, and it can place a strain on relationships. If the attempt was not successful, then a lot of times family members may be avoidant or they can become overbearing and overprotective of that individual. They may feel increased vulnerability, and they can also develop suicidal ideation as well. When someone develops suicidal ideation following the suicide or suicide attempt of a close family member or friend, we call that suicide contagion, and that's something that we see quite a bit in the teen population. And then lastly, we have our different resources that you can reach out to for help with suicidal thoughts or behaviors. The National Suicide Hotline is 988. We can also look for resources on the NAMI website, APA, APNA, the CDC, the Suicide Awareness Voices of Education or SAVE resource, the Alliance for Hope for Suicidal Loss Survivors, and one of my favorite organizations, which is a Detroit-based organization called 6 Feet Over. And this helps provide assistance and counseling for family members that have lost someone to suicide. And that wraps up our mental health mini on suicidal ideation and behaviors.